I will talk about session 11 to 14, and this would include the steps 5 to step 10 of the 10 steps of a successful breastfeeding practices. Session 10: Infants with Special Needs. On the end of this session, the participants will be able to discuss breastfeeding infants who are preterm, low birth weight, or have special needs. Second, describe how to assist mothers to breastfeed more than one baby. Third, outline prevention and management of common clinical concerns such as neonatal hypoglycemia, jaundice, and dehydration with regards to breastfeeding. And lastly, outline medical indications for use of food and fluids other than breast milk. Why is breastfeeding particularly important for a baby who is preterm, low birth weight, has special needs, or any baby that is ill? Breast milk is important for babies who are preterm, low birth weight, or have special needs. It protects, provides food, and aids in growth and development. Breast milk is the ideal food for infants. It contains protective immune factors to help prevent infection, also growth factors needed for the development of the gut and other system, and also heal during diarrhea. It also contains enzymes that would digest the milk and easy absorption. And lastly, it contains special essential fatty acids needed for brain development. In addition, breastfeeding calms the baby and reduces pain. It gives the mother an important role in caring for her baby. It also comforts the baby and maintains link with the family. Babies with special needs such as neurological conditions, cardiac problems, or cleft lip palate, and babies who are ill also need breast milk. Breastfeeding continues to benefit older babies and young children who are ill. The approach to feeding will depend on the individual baby and his or her condition. Overall, care can be divided into categories based on the baby's condition. First, there are babies who are not able to take oral feeds. So what we can do is encourage the mother to express her milk to keep up her supply for when her baby can take oral feeds. If possible, freeze this breast milk and use it later. Second, there are babies who are able to take oral feeds but is not able to suckle at the breast. So what we can do is ask the mother to express her milk by tube and also feed the baby by cup if able. Baby able to suckle but not for full feeds. So let the baby suckle whenever baby is willing. Frequent short feeds may tire the baby less than long feeds at long intervals. So give it expressed milk by cup or tube in addition to what the baby can suckle. There are babies who can suckle well, so encourage the mother to feed the baby frequently for protection from infection and for comfort. Lastly, babies not able to receive breast milk, and these are babies who are having some metabolic diseases such as galactosemia, and these babies need specialized milk formula. What are some ways that a special care baby unit can support breastfeeding? So these are the support that we can offer to the mother if the baby is in a special baby care unit. First, arrange contact between mother and baby day and night. So encourage the mother to visit the baby, to touch and care for her baby as much as possible. A mother produces antibodies during infection against bacteria and viruses that she is in contact with. So her baby is able to produce protective factors against many infections when in contact. Second, skin-to-skin contact or kangaroo mother care encourages the mother to hold her baby dressed only in a diaper, beneath her clothing, close to her breast. So the baby can go to the breast whenever he or she wants. Skin to skin contact helps to regulate baby's temperature and breathing. It assists in development and increases the production of milk. So this is the picture of a kangaroo mother care. Third, take care of the mother. So help the mother to stay at the hospital with her baby. If the mother comes from a long distance to visit her baby, ensure that she has a place to rest when she is at the hospital. Encourage also the health facility to provide food and fluids for the mother during hospital stay. Fourth, answer the parents' questions and explain patiently. The parents may be upset, overwhelmed, and frightened when they know that the baby is ill. So let the parents know that you believe breast milk and breastfeeding are important to their baby. Fifth is help to establish breastfeeding. So these are the steps to establish breastfeeding. First, assist the mother to express her milk within 6 hours of birth, expressing 6 or more times each 24 hours. Encourage babies to spend time at the breast as early as possible. If the baby has the maturity to lick, root, suck, and swallow at the breast, he or she will do so without harm. Describe the early times at the breast as getting early to know the breast. Next, the baby can go to the breast while receiving a tube feed. Weight is not an accurate measure of ability to breastfeed. Maturity is more important factor. Until a baby is able to breastfeed, he or she may be fed expressed breast milk. Avoid using artificial teats or breast milk substitutes. How to put a baby to a breast. So this is the picture of how to handle the baby while breastfeeding. So put a baby to the breast when the baby is just starting to wake up. So you can see the early cues that the baby is ready to feed. Suckling movements with his or her tongue and mouth. Sometimes the baby would bring his or her hand to his or her mouth. So help a mother learn how to anticipate these cues feeding time to avoid her baby using up energy by crying. Second, show the mother how to hold and position her baby. One way to hold the baby is with the baby's head supported but not gripped by the mother's hand. The mother's arm should support the baby's body. The baby can be to the mother's side, or the mother can use her hand from the opposite side to the breast that the baby is feeding at. The mother can support her breast with her other hand. Show her how to put 4 fingers under the breast and her thumb on top. Explain to mothers what to expect at feeds. Expect that the baby will probably feed for a long time and that the baby will pause frequently to rest during a feed. Expect some gulping and choking because of the baby's low muscle tone and uncoordinated suckle, especially among preterm infants. Stop trying to feed if the baby seems too sleepy or fussy. The mother can continue to hold her baby against her breast without trying to initiate suckling. Keep the feed as calm as possible. Avoid noise during feeding of these babies. Prepare the mother and baby for discharge. So a baby is feeding effectively and gaining weight. This is one of the gauge that the baby is ready for discharge. The baby is also weighing 1,800 to 2,000 grams before being discharged. And this baby weight depends on on other institutions. Encourage the health facility to provide a place for the mother to come and stay with the baby 24 hours a day for the day or 2 days before going home. Ensure that the mother can recognize feeding signs signs of adequate intake, and able to position and attach her baby well for breastfeeding. Make sure that the mother knows how she can get assistance with caring for her baby after she goes home. Arrange with the mother for follow-up care. More frequent follow-up is needed among preterm infants and those who are critically ill babies. Breastfeeding more than one baby. Mothers can make milk enough for 2 babies and even 3. The key factors are not milk production, but time, support, and encouragement from healthcare providers, family, and friends. So, encourage the mother to get help with caring for other children and doing household duties so she can feed her babies. Breastfeed by lying down to conserve energy when possible. Eat a variety of diet to take care of herself. Try to spend time alone with each of the babies so that she can get to know them individually. A mother of twins may prefer to feed each baby separately so that she can concentrate on the positioning and attachment. When the babies and mother are able to concentrate on the positioning and attachment, when the babies and mother are able to attach well, then the mother can feed them together if she wishes to reduce feeding time. If one baby is a good feeder and one baby less active, alternate breasts so that the milk production remains high in both breasts. The baby who feeds less effectively may benefit from breastfeeding at the same time as the baby who feeds more effectively, thereby stimulating the oxytocin reflex. Do not stop breastfeeding when a new baby arrives. The mother will produce enough milk for both if she cared for herself, which includes eating well and resting. Whether there is a shortage of food in the family or not, breast milk may be a major part of the young child's diet. If breastfeeding stops, the young child will be at risk, especially if there are no animal foods in the diet. Feeding the mother is the most efficient way of nourishing the mother, the new baby, and the young breastfeeding toddler. Abrupt cessation of breast milk should always be avoided. So how can we prevent and manage common clinical concerns uh, among problematic infants? Many instances of hypoglycemia, jaundice, and dehydration can be avoided by implementing practices such as early skin-to-skin contact, rooming in so that frequent feeding is easy, encouraging milk expression and cup feeding. Do not give water to the baby. Observe all babies in the first few steps or in the first few days to ensure that they are learning to suckle well. Hypoglycemia means a low blood glucose level. So premature or small for gestational age, ill or whose mothers are ill, develop hypoglycemia. There is no evidence to suggest that low blood glucose concentrations in the absence of signs of illness are harmful in healthy full-term infants. Breastfed babies have better control of blood glucose level as compared to artificially fed babies because in breastfed babies, they compensate for low blood sugar by using body fuels such as glycogen stored in the liver. Full-term healthy babies do not develop hypoglycemia simply through underfeeding, but if hypoglycemia is seen among full-term healthy infants, they should be further investigated for an underlying problem. The signs of hypoglycemia would include reduced level of consciousness, convulsions, abnormal tone of muscles, and apnea. Prolonged jaundice. It's a jaundice that persists 3 weeks to 3 months of life. Presence of prolonged jaundice should rule out abnormal jaundice. It is a rare problem among infants who are feeding well with good weight gain or mild level of jaundice. Abnormal pathological jaundice is not related to feeding. This is usually evident at birth or within the first or 2 days of life. The baby looks ill. So, in these cases, breastfeeding should be encouraged except in the very rare metabolic condition of galactosemia. Treatment of severe jaundice is through phototherapy in order to break down bilirubin. Also, another treatment is very frequent breastfeeding and giving express milk if the baby is too sleepy to feed. Dehydration. Healthy exclusively breastfed infants do not require additional fluids to prevent dehydration. Babies with diarrhea should be breastfed more frequently or to continue breastfeeding while giving oral rehydrating solution to hydrate the babies. Frequent breastfeeding provides fluid, nutrients, and provides protective factors. Growth factors in breast milk aid in the regrowth of the damaged intestine. So, diarrhea would heal faster. Babies who have difficulty in breathing should be fed small amounts frequently as they tire easily. Breastfeeding provides the infant with nutrients, bodies, calories, fluid, and comforts the distressed baby and mother. Babies with Down syndrome or neurological difficulties can breastfeed. If the baby is not able to breastfeed, breast milk is still very important. There are some ways to assist the mother with baby with neurological difficulties. First, encourage early contact and an early to start feeding. The baby may need to be awakened for frequent breastfeed and stimulated to remain alert during feeding. Help the mother to position and attach the baby well. Support the mother's breast and her baby's chin to stabilize the baby's jaw and maintain good attachment throughout the feed. She can gently cup the baby's chin between her thumb and first finger and cup the remaining 3 fingers under her breast. In addition, help the mother to understand that it is not breastfeeding of itself that is taking time. The mother may need to express her milk and feed it to her baby in a cup. Avoid artificial teats and pacifiers as these babies may find it very difficult to learn to suck from both a breast and an artificial teat. Some babies with neurological difficulties gain weight slowly even if they receive enough breast milk. Some babies with neurological difficulties may have other health challenges, such as in those patients or babies with cardiac problems. Sometimes breastfeeding is not started or it is stopped without a clear medical indication. So it is very important to distinguish between the following. Babies who cannot be fed at the breast but for whom breast milk remains the food of choice. Babies who should not receive breast milk or any other milk, including the usual breast milk substitutes, and babies for whom breast milk is not available for whatever reason. So, babies who cannot feed at the breast may be fed expressed milk by tube, cup, or spoon. Ensure that the baby gets the hind milk that has the highest fat content to help the baby grow. Babies with inborn errors of metabolism such as galactosemia, fetal ketonuria, or maple syrup urine disease may require partial or complete feeding with a special breast milk substitute. The mother may be away from the baby, severely ill, or have died, or is HIV positive and made an informed decision not to breastfeed. You can do the replacement feeding. Babies with medical conditions that do not permit exclusive breastfeeding need to be followed up by a suitably trained health worker. and this needs individualized feeding plans. In summary, breast milk is important for babies who are preterm, low birth weight, or have special needs because it protects, provides food, and aids in growth and development. The approach to feeding will depend on the individual baby and his or her condition. Overall, care can be divided into categories based on the baby's ability to suckle. And these are the following. Baby not able to take oral feeds. So baby able to take oral feeds but is not able to suckle at the breast. Baby able to suckle but not for full feeds, or baby can suckle well. Take care of the mother with fluid, food, rest, and help her to be in close contact with her baby. Expect that the baby will pause frequently to rest during the feed. Avoid loud noises, bright lights or stroking, jiggling or talking to the baby during feeding attempts. Prepare the mother and baby for discharge by rooming in, encouraging skin-to-skin contact, allowing time to learn to breastfeed and recognize feeding signs or cues, and to know how to get help when at home. Arrange early follow-up among babies who are preterm, ill, or low birth weight. Mothers can make enough milk for 2 babies and even 3. The key factors are not milk production but time, support, and encouragement from healthcare providers, family, and friends. Prevention and management of common clinical concerns. By implementing practices such as early-to-skin contact, early and frequent breastfeeding, and by rooming in, and milk expression and cup feeding if the baby is sleepy and weak, and avoiding water supplements can avoid many instances of hypoglycemia, jaundice, and dehydration. Infants with medical conditions that do not permit exclusive breastfeeding need to be seen and followed up by a suitably trained health worker. Does the baby need breast milk substitutes? Exclusive breastfeeding is the norm. In a small number of situations, there may be a medical indication for supplementing breast milk or for not using breast milk at all. It is useful to distinguish between the infants who cannot be fed at the breast but for whom breast milk remains the food of choice, such as infants who are very weak, infants with suckling difficulties or oral abnormalities, infants who are separated from their mother who is providing expressed milk. These infants may be fed expressed milk via tube, cup, or spoon feeding. Infants who may need other nutrition in addition to breast milk are those infants who are low birth weight or very preterm infants, especially those born less than 1,500 grams or 32 weeks gestational age. Next would be infants who are at risk of hypoglycemia because of medical problems when sufficient breast milk is not immediately available. Third, infants who are dehydrated or malnourished when breastfeeding alone cannot restore the deficiencies. These infants require an individualized feeding plan, and breast milk should be used to the extent possible. Efforts should be made to sustain maternal milk production by encouraging expression of milk. Milk from tested donors may also be used. Hind milk is high in calories and particularly valuable for low birth weight infants. Infants who should not receive breast milk or any other milk, including the usual breast milk substitutes, and need a specialized formula are infants with certain rare metabolic conditions such as galactosemia, who may need feeding with a galactose-free special formula, or phenylketonuria, where some breastfeeding may be possible, partly replaced with phenylalanine-free formula. Next, infants for whom breast milk is not available. So, these are among mother who had died or is away from the baby and not able to provide express breast milk. Breastfeeding by another woman may be possible in these cases. The need for a breast milk substitute may only be partial or temporary. Breast milk from preterm infants contains more protein, sodium, and calcium than the full-term milk. So preterm infants often need extra protein, so this is helpful. First, breast milk can give an energy value of 65 kilocalories per 100 ml at a volume of 200 ml per kilogram per day, which is equivalent to energy intake of 100 kilocalories per day. Excess expressed breast milk can be left to stand for a short while, and the fat-rich hind milk will rise to the top. The cream can be added to the regular milk feed, which is higher in energy value. Addition of fortifiers and formula to the breast milk make the baby grow more quickly. Mother worried that her milk is not enough for her baby. So just reassure that her milk is good for her baby. If there is a medical need for additions to the breast milk, you can explain to the mother that for a short period her baby has extra needs. Mix breast milk with formula for better absorption rather than giving an alternate feeds. It is not a standard policy for all infants in the unit. Babies who are breastfed do not develop hypoglycemia as compared to those who are artificially fed babies because babies who are breastfed compensate using their body fuels such as glycogen stored in the liver. Term healthy babies do not develop hypoglycemia simply through underfeeding. So, if hypoglycemia occurs in term healthy babies, they should investigate for a possible underlying problem. Signs of hypoglycemia would include reduced level of consciousness, convulsions, abnormal tone or floppy muscles, and apnea. A doctor should be seen immediately if these signs of hypoglycemia are seen in infant. Physiological jaundice is the commonest kind of jaundice, and it does not indicate an illness in the baby. Physiologic jaundice appears on the second or third day of life and clears by the 10th day. This jaundice is due to fetal red blood cells being breakdown faster than the baby's immature liver cell can handle. As the baby's liver matures, jaundice decreases. So bilirubin is excreted in the stools and not in the urine. Therefore, water supplements do not help to reduce the level of bilirubin. Prolonged jaundice. Jaundice may persist for 3 weeks to 3 months, and babies with prolonged jaundice should be seen to rule out abnormal jaundice. Babies who are feeding well, has good weight gain, with mild level of jaundice, this prolonged jaundice is rarely a problem. Abnormal or pathological jaundice is not usually related to feeding. This pathological jaundice is evident at birth or within the day. The baby usually is ill. So breastfeeding should be encouraged except in the very rare metabolic condition of galactosis. Treatment of severe jaundice. Phototherapy is used in severe jaundice to break down bilirubin. Very frequent breastfeeding is important to avoid dehydration. Give expressed milk if the baby is sleepy. Water or glucose water supplements do not help as they reduce the intake of breast milk and do little to reduce jaundice. Babies with cardiac problems usually tire easily upon breastfeeding. Short, frequent feeds are helpful. The baby can breathe better when breastfeeding. So breastfeeding is less stressful and less energy is used is used and has a better weight gain. Breast milk provides protection from illness, thus reducing hospitalization and helping growth and development. Babies with cleft lip and palate, breastfeeding is still possible, but they are at risk for otitis media and upper respiratory infections, so breast milk is especially important among these babies. So how do we breastfeed babies with cleft lip and palate? Hold the baby so that his or her nose and throat are higher than the breast. This will prevent milk from leaking into the nasal cavity, which would make it difficult for the baby to breathe during the feed. Breast tissue or the mother's finger can feel a cleft in the lip to help the baby maintain suction. Feedings are likely to be long among these babies, so encourage the mother to be patient as the baby tires easily and needs to rest. Express her milk and supplement and feed with a cup or breastfeeding supplementer. Following surgery to repair the cleft, breastfeeding can be resumed as soon as the baby is alert. For infants requiring surgery, breast milk is easily digested, so it requires a shorter fasting time than formula-fed infants or infants taking other foods. So in general, babies do not need to fast more than 3 hours. So it should be discussed with the parents the ways of comforting the baby during the fasting period. So as the baby is fully awake after surgery, breastfeeding may be started. Breastfeeding soon after surgery helps to relieve the pain. It also comforts the baby and provides fluid and energy. So, if the baby cannot take large amount of breast milk right after surgery, the mother can express breast milk and let the baby suck on an empty breast once the baby is stable. Contraindications to breastfeeding or feeding expressed breast milk to infants are the following. Those infants diagnosed with classic galactosemia, which is a rare metabolic disorder. Another are babies born to mothers infected with human immunodeficiency virus or HIV. Third, mother who's in illicit use of street drugs such as PCP or cocaine. Next is mother who has suspected or confirmed Ebola virus disease and those mothers taking cancer drugs or Mothers should temporarily not breastfeed and should not feed expressed breast milk to their infants if the mother is infected with brucellosis, the mother is taking certain medications, the mother is undergoing diagnostic imaging with pharmaceuticals, or the mother has an active herpes simplex virus infection with lesions present on the breast. But the mothers can breastfeed directly from the unaffected breast if lesions on the affected breast are completely healed, and that is to avoid transmission. Exclusive breastfeeding is recommended for the first 6 months of life. Giving supplements is dangerous because of the following. It can overfill a baby's stomach, reduce milk supply, it can lead to obesity, it can increase the risk of diarrhea and other illnesses, it will expose the baby to allergens and intolerances, it can reduce the mother's confidence, and cause unnecessary and potentially damaging expense. Some other reasons, in addition to what has been mentioned, would be difficulties in feeding and caring for her baby. The mother may also lack knowledge and skill in supporting breastfeeding, that's why she is giving supplement. Stressful atmosphere where a quick temporary solution is chosen in preference to solving the problem may be another reason why the mother is giving supplement. Prelacteal feeding or offering formula may alter the gastrointestinal mucosa and allow the transmission of virus. For an HIV-positive mother who has decided not to breastfeed, She can use a replacement food, which is unacceptable medical reason for giving her infant a milk formula. Even if many mothers are giving replacement feeds, this does not prevent a hospital from being designated as baby-friendly if those mothers have all been counseled, tested, and made genuine informed choices. These are some of the additional benefits of rooming in for the baby, mother, and hospital. Responded more quickly with less crying, less of the baby's energy stores, and reducing temptation to give artificial feeds. Jaundice is less frequent and does not reach such high levels. Higher maternal attachment, less parental abuse, and less abandonment are linked with rooming in. There is also reduced infection rates. It gives immune protection through milk. There is reduced use of artificial feeds, reduced need for nursery space, and save the hospital money. There is also less use of post-discharge health services. Mothers who are HIV positive and mothers who are not breastfeeding also benefit from rooming in. Rooming in assists them to get to know their baby and become confident in caring for the infant. Bed sharing or co-sleeping can help a mother and baby to get more rest and to breastfeeding frequently. However, co-sleeping is not recommended if either the mother or the father is a smoker, under the influence of alcohol or drugs that may cause drowsiness, or usually tired and might not respond to the baby, or ill or has a condition which could alter consciousness such as epilepsy, unstable diabetes, or those who are very obese and those who are very ill, or if the baby or any other child in the bed is. These are the guidelines for safe bed sharing or co-sleeping. Discuss benefits of and contraindications to bed sharing so that parents are well informed. Use a firm mattress, not one that is sagging. Sleeping on a sofa or cushions with a baby is not safe. Keep pillows well clear of baby to avoid accidents. Cotton sheets and blankets are considered safer than a soft kilt. Dress the baby appropriately. Do not swaddle in wraps or blankets if bed sharing or overdress. The mother's body is enough to provide warmth for the baby. The mother should lie close to her baby, facing baby, lying on his or her back except when feeding. Ensure that the baby cannot fall out of bed or slip between the side of the bed and the wall. Ensure that the mother can easily call for assistance if she has difficulty moving in bed. Check the well-being of the mother and baby frequently, ensuring that the baby's head is uncovered and that the baby is lying on his or her back if not feeding. When handing over care to another staff member, make them aware of those mother and babies who are bed sharing.